But we're here today, Mr. President, to talk about something else, and that is how to bring costs down in health care. As we look at how to expand health care, as we look at how to improve the quality of health care, there must be work done to contain the costs. And I believe, based on what I've seen in my state, you can actually reduce costs and improve quality. A few weeks ago, President Obama convened a health care summit to bring together industry leaders, providers, and advocacy groups to discuss our opportunity to move forward with serious health care reform. That reform should begin with the Medicare system. Medicare is one of the most valued social programs that our country has produced in the last half-century. Yet it is also a program in dire need of reform if it is to survive on a sound financial footing and continue to provide the fine medical care that our seniors have come to expect from it. And change is needed now. By 2011, the first baby boomers will enter the Medicare system, and by 2016, the number of Medicare beneficiaries will increase by almost 5%. This past winter, I convened a health forum in Minnesota to discuss the various challenges affecting the Medicare system. The message is clear. Without action, costs will continue to rise and waste will proliferate. Medicare is the single largest purchaser of health care, and its policies directly affect nearly every health care provider. Medicare's payment system, coding, quality reporting, and record keeping are the industry standard. Spending for the Medicare program is projected to increase 114% in the next 10 years. 20% of Medicare beneficiaries suffer from one of 5 chronic diseases. Medicare spends 66% of its annual budget to treat this group. 2/3 of Medicare spending, Mr. President, helps 1/5 of Medicare beneficiaries. And if we are going to sustain Medicare as a healthy, high-quality program that Americans deserve, we must do something to address these challenges. In short, we need to reform Medicare so that it addresses efficient, high-quality care. As it happens, doctors and hospitals in many regions of the country, including my state of Minnesota, practice exactly this kind of high-quality, low-cost medicine, and they should be rewarded for it. But Medicare does not reward them. Instead, it punishes them. In fact, at the Health Summit last week, President Obama actually asked the gathered group, why should we punish Minnesota because other states are less efficient? The problem is that despite periodic efforts at reform, Medicare pays for quantity, not quality. More tests and more surgeries mean more money, even if the extra tests and operations do nothing to improve a patient's conditions. States that have historically delivered excessive procedures are still rewarded for the wasteful practices of the past, while efficient states, such as Minnesota, are punished. Now, if you look at this chart, you'll see that the areas in dark blue are the ones that receive the lion's share of Medicare payments. The light blue areas, states like Minnesota, Montana, Iowa. I see Maine is looking good. I see the senator from Maine across the way. And a number of states in the area, you can see are areas where Medicare spending is low, but quality of care is high. It's as if there was a huge transfusion tube, Mr. President, that basically takes taxpayer money from one region, one area of the country, and puts it in another. And it's not to say people aren't sick in other parts of the country, that they don't deserve that help. But as we look at the limited resources, we have to figure out what's working and how come areas of the country that tend to have the lowest health care costs also have the highest quality health care. It's not what you would think. You would think, well, the highest cost must have the highest quality. That tends to happen sometimes in clothing and other things. Well, that's not what's going on in this country right now. Regions with more specialists and more hospital beds tend to provide more. According to the Dartmouth Institute for Health Policy and Clinical Practice, high-cost regions in Medicare boast 32% more hospital beds, 31% more doctors, and 65% more medical specialists. In other words, supply is driving demand. The result is that Medicare pays vastly more in some parts of the country than it does in others for medical care that is no better. Medicare's own reports show that the quality of care is higher in many of these low-cost states. In fact, Medicare spends more in places like Florida and New Jersey than it spends in states like Minnesota and Oregon. Let me give you just one example. In Miami, Florida, Medicare spent roughly $15,000 per patient per year in the year 2005. In Minneapolis, a Medicare patient received about $7,000 worth of care that year. To put it another way, Medicare will spend $50,000 more on a 65-year-old patient in Miami, Florida, over the course of his or her lifetime than on a comparable patient in Minneapolis. $50,000, that's a lot of money. At $2.4 trillion per year, healthcare spending represents close to 17% of the American economy, and it will exceed 20% by 2018 if the current trends continue. Now, you look at this internationally. As you can see, the United States spends far more money on health care than any other nation without getting better care. We can and we must do better. A number of models are out there to provide direction for the future. The Mayo Clinic, based in my home state of Minnesota, is renowned for the effective care it provides at a reasonable cost. Now, just think about this. This was a Dartmouth study that came out, and it showed this. If the rest of the hospitals in the country used the same kind of high quality with very high quality efficiency ratings from families and high efficient care as the Mayo Clinic does in the last 4 years of a patient's life, the country, the taxpayers of this country would save $50 billion over 5 years. $50 billion over 5 years by simply following the protocol of having a more organized, efficient delivery system with one primary doctor, with experts that work together, without duplicate tests. $50 billion every 4 years just by following a set protocol with some of the highest quality ratings in the country. The Congressional Budget Office has also studied the problem and found the potential for huge state savings. This chart reflects that Medicare spending would fall by 29% if spending in medium and high spending regions were the same as that in low spending regions. That's a CBO. So how do we change the Medicare system in a way that will reduce these disparities and reward our doctors for doing the right thing? Real reform will start, Madam President, when the system starts paying for quality. Here are the 3 priorities I plan to start working on immediately. First, we need to enhance Medicare incentives that reward quality care. For many illnesses and conditions, the medical profession has widely accepted practice guidelines that result in better health care outcomes, such as when to give aspirin to heart patients and how often to perform cancer screenings, but they're not always followed. A recent RAND Corporation study found that adults receive recommended care for many illnesses only 55% of the time. Medicare needs to reward doctors and hospitals for doing the right things and achieving improvement in care. These quality guidelines can be the basis for Medicare payments. Second, we need to rethink the Medicare payment system. Right now, Medicare pays for tests, visits, and other procedures one by one, giving providers an incentive to order more and more services. We need to have better coordination of care and less incentive to bill Medicare purely by volume. Increasing the bundling of services in Medicare's payment system has the potential to deliver savings and start rewarding value and not volume. Third, we need to address the shortage of the number of primary care physicians who are currently practicing across our country. Today, effective primary care is severely undervalued in our healthcare system. Yet research suggests that improving access to primary care and reducing reliance on specialty care can improve the efficiency and the quality of healthcare delivery. To accommodate the needs of an aging population, we need to promote primary care and transition away from specialty-intensive health care. The health care system we have now needs major improvement. That means transforming the system to pay doctors for the quality care they provide and to turn the current disconnected, reactive health care system into one that is integrated and concentrates on delivering the best care for patients. And again, I want to stress this, when we talk about saving costs, you look at these studies, those states that are most efficient, those areas that are most efficient have the high quality care. And I leave you with that figure. Mayo Clinic, last 4 years of a patient's life, if those protocols were followed across the country, we would save $50 billion every 5 years in taxpayer money. That's an independent study, $50 billion. I know we can do better than this, and at the same time as we reduce costs, we can improve the quality of care that our nation's seniors deserve. Working together, we can give them the system they deserve. Thank you, Madam President, and I yield the floor.